Good evening, everyone. We welcome you to the online teaching program for postgraduates
Priya,
in pathology.
Priya, just hold on.
Yes,
I
sir.
think you take a minute because it's 6:58.
Okay, sir.
Because people are registering now. Slowly.
It's time now, I think, and 600 people almost are here now.
Yeah, I guess so. Yeah, start, Priya.
Good evening, everyone. We welcome you to the online teaching program for postgraduates in pathology. Today's topic is approach to encapsulated lesions of thyroid by Dr. Anita Bogus, ma'am. She is presently the lab director at Center for Oncopathology, Mumbai. We welcome you, ma'am. And the chairperson for today's talk is Dr. Asavari Patil, ma'am. She is associate professor at Tata Memorial Center, Mumbai. Welcome you, ma'am.
Okay.
And the webinar host, sir, Dr. Anita, ma'am, and Dr. Sumit, sir. The moderators for today's talk are myself, Dr. Priyavatna, and Dr. Tanvi Kulkarni. In case of any audio or video failure, please click to refresh or reconnect, and please type your questions in the comment section. Questions will be taken at the end of the talk. And these are some of the reminders. Some of the disclaimers. And with this, I welcome Dr. Anita, ma'am, to deliver the talk. Anita, ma'am.
Thank you, Priya. Thank you, Tanvi and Shweta and Asavari, and of course, my friend Sumit. I'll just turn my screen share on. Can you see my screen?
No, ma'am, not yet. Ma'am,
Not yet?
entire screen and then click share.
Yes, I did. Now let me see.
Yes,
Yeah.
ma'am. We can.
You can see it now?
Yes, yes.
Very good. All right.
Perfect.
Then I can start, and let me start first with the slide that we all start with, and that's a disclaimer. You know that this is meant solely for teaching purposes, and whatever slides or other material has been duly acknowledged in this particular talk of mine. So let me start with this particular slide, and it says here, encapsulated follicular patterned lesions of the thyroid. I really don't think that there are any other encapsulated lesions of the thyroid which are not follicular patterned. And we'll come to that in a minute. And I'm going to do this through a historical perspective. You see, when you reach my age, history matters a lot to you because things have moved from where they were to where they are now, and if you have lived as long as I have in pathology, then you have seen the transition and the changes that have occurred. And that's one thing that I want to tell a lot of youngsters over here, that science is never set in stone. Science is always tentative. What we believe today, based on evidence, may change tomorrow when the evidence has changed, when we understand more about the lesions or lesion that we are talking about. So we must understand history. And this has been said very well by a philosopher by the name of George Santayana. He said, those who do not remember the past are doomed to repeat it, and which means that we must know history. I think history is very important even for those of us who are in clinical medicine, because if you don't know your history, then you are doomed anyway. Well, let me start with the classification of thyroid carcinoma, and I put up a very encapsulated version of this WHO 2004. Now, if you look at WHO 2004, you have tumors of follicular epithelium, which are well differentiated or differentiated, those that are poorly differentiated, and then of course you have the undifferentiated and anaplastic tumors. And these tumors of follicular epithelium have to be distinguished from those of C-cell derivation. And you have, those are the medullary carcinomas, and sometimes you have other neuroendocrine tumors in the thyroid. And then of course you have mixed follicular and C-cell types. But please, this follicular epithelium is the epithelium that lines the follicles, and should be distinguished from when we talk about follicular tumors. The follicular epithelium gives rise to both follicular and papillary tumors, also poorly differentiated, and anaplastic tumors. Now, when I was growing up in pathology, we just had follicular carcinoma, follicular adenoma, follicular carcinoma, papillary carcinoma, and mixed follicular and papillary tumors. But along the way, the mixed follicular and papillary tumors were dropped because it was realized that almost all of these so-called mixed follicular and papillary tumors were actually papillary tumors. Now, how did that happen? Now, that happened because, as we shall see in this slide, that it was realized that tumors that had these typical nuclear features, whether they were papillary looking tumors or follicular looking tumors, or those with papillary and follicular structures, seemed to, if they were carcinomas, they seemed to have the behavior not like those of follicular carcinomas, but of papillary carcinomas. And so all of these tumors, whatever their their appearance, follicular, papillary, or mixed, were all called papillary carcinomas. There are, by the way, up to now, no papillary adenomas. So now there is something that is becoming very evident, and that is we are not making definitions of follicular and papillary based on a morphology which is either follicular and papillary. We are making this diagnosis based on nuclear features. And these nuclear features are ground glass, large, pale, vesicular with grooves, and pseudo-inclusions. And since we have been remembering one Rosai these days because he passed away just a week or so ago, he wrote this very interesting editorial in which he said, at present, a thyroid tumor can have papillary, follicular, solid, trabecular, cribriform growth. It can be composed of large, small, blah, 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 columnar cells. It can be encapsulated, and that's what we are going to be discussing today, minimally invasive or widely invasive. In sum, it can have any of these features and more, but as long as it has what we have just defined as PTC type nuclei, it is thought to be a papillary thyroid carcinoma or one of its innumerable variants. And you know now, in the new WHO 2017, there are over 10 different variants of papillary thyroid carcinoma. So as it stands, it stood, at least in 2008, that any tumor, if it had the nuclear features of papillary thyroid carcinoma, was called a papillary thyroid carcinoma. It was called follicular, or it was papillary, or it might have had mixed papillary and follicular lesions, morphology. So then, what about the follicular neoplasms? And I think it becomes very clear that a well-differentiated neoplasm of thyroid follicular epithelium that is not a papillary carcinoma is a follicular neoplasm. In other words, a tumor that does not have the nuclear features of a papillary thyroid carcinoma is called a follicular neoplasm. And it is always follicular, because if it were papillary, then it was not likely to be called a follicular neoplasm. So it's always follicular, but it must not have the nuclei of a papillary thyroid carcinoma. So this diagnosis was by exclusion. And you had two follicular neoplasms. One was an adenoma, and the other one is a carcinoma. Now, an adenoma is relevant to us today because it's an encapsulated lesion. It has a thick or thin capsule with a follicular lesion or a follicular patterned lesion within that capsule, within the tumor, and it does not have the nuclei of a papillary thyroid carcinoma. That's number one. And it does not have any signs of invasion, either of the capsule or of a vessel. So what is a follicular carcinoma then? It's a there were two variants which were mentioned in WHO 2004. One was minimally invasive. That is a tumor with all of the features of an adenoma, which means that it was entirely encapsulated. It was a follicular patterned lesion, but it showed invasion of the capsule and or blood vessels. And of course, necrosis was absent. Any other carcinoma that had a follicular appearance without the nuclear features of a papillary thyroid carcinoma was called widely invasive. And you can see two pictures here. You can see the thick capsule, and you can see a mushroom-like invasion of the capsule. And here you can see invasion into a vessel which is situated within the capsule. So everything seemed to be absolutely fine. It was so easy. If you had an encapsulated follicular patterned neoplasm, remember that you have no papillary adenomas. It's very important to realize that. So when you have an encapsulated follicular pattern neoplasm, and if it had the nuclear features of papillary thyroid carcinoma, we called it a papillary carcinoma. This was in WHO 2004. If the nuclear features of papillary carcinoma were absent and the lesion was non-invasive, then it was called a follicular adenoma. And if it was invasive, it was called a follicular carcinoma. But this is the real world, and we don't live in paradise where everything is ideal. And very soon, trouble in paradise occurred. Now, what was the problems over here? And the first problem was what constitutes encapsulation. And this is something that is sometimes difficult to make out. You have some capsules that are extremely thin. And then how do you distinguish a dysfunctional nodule from a follicular adenoma? There's no invasion, of course, but you have nodules in a nodular goiter. Now, how do you distinguish a solitary nodule of a nodular goiter, or what we call a dysfunctional nodule, from a follicular adenoma? Also, what are the criteria that we use for invasion in an encapsulated tumor? If it's very obviously invasive and there is disease that has gone beyond the capsule, it's easy. But it can be difficult sometimes, and there are criteria that people have laid down, but not everybody agrees, and not everybody it's not easy for, in all cases, to actually to apply those criteria in every case. So this is essentially, how do you distinguish an adenoma from a minimally invasive follicular carcinoma? And the last, which really was the cause of a lot of anxiety in diagnosis, was, all right, we knew if the whole lesion had the nuclear features of papillary thyroid carcinoma, we would call it an encapsulated variant of papillary thyroid carcinoma, follicular variant of papillary thyroid carcinoma. But suppose these nuclear changes were equivocal, or suppose they were very focal, then what were these? What did we call them? So these were the real problems that were thought about. There were lots of papers that were written on these issues. So let's take them one by one and see where we have how we have sorted out the problems, if we have sorted them out at all. And these were really the causes of pathological thyrophobia, because there was ambiguity in the diagnosis of these follicular pattern lesions. But worse still, there were controversies in the management of differentiated thyroid carcinoma. So you couldn't really get even the surgeons to agree on how they should manage cases that pathologists called differentiated thyroid carcinoma. And this led to what I call, what if I get it wrong syndrome? Because there are these borderline and indefinite lesions. And I think pathologists have spent sleepless nights trying to figure out what they should call these encapsulated lesions, because they were not always easy. It's very easy to write criteria, but very difficult sometimes to apply them. So let's just take this first. It's not a big deal. Dysfunctional nodule versus follicular adenoma. If you go to the textbooks, they will tell you that a follicular adenoma should be solitary. It must have a complete capsule. Compressed thyroid tissue should be seen beyond the capsule. And the morphology within and without the nodule should be different. Now that's the standard definition of a follicular adenoma. And I'm going to show you this picture. These are three nodules in a section of the thyroid. And you see two nodules over here at the bottom of the screen, which I have labeled dysfunctional nodules, which they are because they don't have a capsule. You can see them applied to the surrounding thyroid tissue without a capsule in between. But then you have this large nodule. And yes, you can see a capsule, and it was a capsule all throughout. But when you look at this nodule, the large nodule, and this, what is very obviously a dysfunctional nodule, you see a similar sort of picture. All right, you see large colloid-filled follicles, you see small follicles, you see medium-sized follicles, which is exactly what you see in this nodule. And the rest of this thyroid was also nodular. So what is this? Is this really a follicular adenoma in a nodular goiter, or are these all nodules, dysfunctional nodules in a nodular goiter? Now, you might think it doesn't matter, and I think it doesn't matter. But is there any way at all that you can tell a follicular adenoma from a dysfunctional nodule? Is there a molecular way? Is one neoplastic and therefore is clonal and the other one is not? And the answer is no. In an encapsulated nodule in a multinodular goiter or a follicular adenoma, 70% of dysfunctional nodules have been found to be clonal. And some of them also express the molecular markers of follicular adenoma or a follicular carcinoma, and that is RAS mutations and the PAX8 PPR gamma rearrangement. So when something looks like a dysfunctional nodule. It doesn't have a capsule, etc. Sometimes you can see that this is clonal, and other times you may have something that is encapsulated and may not show any either show clonality or show these mutations. So I think that we are really making a mountain out of a molehill. A lot of people stress this issue of not having more than one follicular adenoma in the thyroid. I think that is not something that you can easily apply, because you have, what is the status of more than one encapsulated follicular lesion in a multinodular goiter? Are you going to call them multiple dysfunctional nodules or multiple adenomas? And I think the answer is what I've already said. It just makes no difference in practice, as both are benign. And I had a mentor when I was at the Royal Marsden Hospital, and he would tell you, call it anything you want, doctor, but don't call it cancer. And that, I think, is the message over here. We don't need to fret over dysfunctional nodules versus follicular adenomas. You feel that the capsule is complete. You feel that there are 3 of these kind of nodules with the complete capsules. Please call them follicular adenomas if you want, or call them dysfunctional nodules, as the case may be. We come to a more important problem, and that is a follicular adenoma versus a minimally invasive follicular carcinoma. Now, a minimally invasive follicular carcinoma was defined as an encapsulated follicular neoplasm which demonstrates invasive characteristics. And here comes this issue. What is invasion of the capsule? What constitutes that? Now, a lot of the literature says that you must have full thickness invasion of the capsule, and that capsule is usually thick. Vascular invasion was tumor embolus within or outside the fibrous capsule, not within the nodule itself, and that embolus should be covered by endothelium. Now, all this sounds very good. And here, as I showed you before, is the classical example of invasion of the capsule, as well as invasion of a vessel within the capsule. And I'm sure everybody has seen this this cartoon from Ronald Gossaine's, I think it's a publication in 2009, where we will concentrate on the capsule, and this green rim is the capsule. And I want you to look at what is considered to be capsular invasion. C is capsular invasion. You've got a straightforward tongue of thyroid follicular cells that have gone through the capsule. I don't think anybody was going to quibble with that, or quibble with what is H. You might have some problem with E, in the sense that you sometimes see nodules outside the capsule, and then you're not very sure, is this actually a portion of the tumor that is here as a nodule, or is this just a nodule in the surrounding thyroid tissue? But if you can show that these two look similar, what's within and without, yeah, all right, this is capsular invasion. But I'd just like you to look at this. Now, this has got a green zone beyond in D. If you look at D, it has a green zone beyond. And then you would say, but that's a capsule, and it hasn't actually invaded through that capsule. But here is the problem. When a tumor is invasive, and particularly a low-grade tumor, as it's making its way through the capsule can actually be duplicated. Because after all, why does a capsule ever form in a benign tumor? It does this because it is the host response to the expansion of the tumor. Now, if you have a tumor expansion through the capsule, and if it is slow, you may get a duplicated capsule beyond. Okay, so here, that's why I think this has been said, yes, because there is another capsule, or portion of the capsule that has formed. But then you might ask the same question for B as well as for I. How do you know in any, because this is an idealized cartoon where you have a nice round circular capsule. What if the nodule is not entirely spherical and you have little lumps and bumps, and you do not know whether this mushroom like thing, which has not gone full, through the full thickness of the capsule, is actually a fully invasive, or has gone through the full thickness, and there is now a little rim of new capsule that has formed around it. And this, I tell you, is a difficult issue when you are looking at tumors. Now, all the rest of it, these little islands of thyroid tissue within the follicular tissue, within the capsule, you can ignore, because sometimes they're just tangential cuts or something through the lesion. I won't waste too much time on vascular invasion, because it must show tumor in a vessel either outside the capsule or within the capsule, and it should actually have either some amount of endothelium around it, or may actually show a clot. In other words, there could be a thrombus in that particular area. So now that we've looked at this, let's see, what do we think? Is this invasion or not? You have a thick capsule, you can see this. You can see the mushrooming of the tumor through this capsule. And there seems to be a whole lot of fibers here, very thick collagenous fibers beyond. Well, according to the so-called full thickness invasion of this of the capsule, many people will say this is not a full thickness invasion, and therefore it is not a minimally invasive follicular carcinoma. And here is something that came from Sister, who published this in 2019. And let me just say what he says. Now, this is exactly like this. There's a hook-like lesion. And he says partial but incomplete penetration of the capsule by the tumor has been regarded as being insufficient to qualify for invasion, and therefore for a diagnosis of carcinoma. However, a consensus regarding the significance of such a finding is not yet available. So, I don't know. If you ask me, my personal opinion is that I would call this a minimally invasive follicular carcinoma. What about this? Now here you have, yes, I think it looks like an invasion through the capsule. And you have these intracapsular vessels. You've seen one here, you see another one there. And there is a fibrinous thrombus in that. This is a higher powered view of the same. I cannot demonstrate in this case an endothelial lining that is seen, particularly if you look at the lower bit around this lesion. I'm not even sure whether I can tell whether this is entered into the vessel, but I can see fibrinous exudate, or not, it's not an exudate, it's a fibrinous thrombus inside this vessel, and I would regard this as invasion or angio-invasion. Now, if you think that this is a problem only with those of us who are not experts at thyroid pathology, here you have on the left-hand side Sister, who has not changed his view. This is 2006. You saw what he wrote in 2019. This is the same hook-like invasion of the capsule in this case. This I don't think many people would regard as capsular invasion, but I think some people would regard this. And when I say some people, not just me. Here on the right-hand side, you see Baloch and Livolsi. What do they call this? Capsular invasion in follicular carcinoma, showing tumor cells invading into, but not the tumor capsule, in a hook-like fashion. And then in brackets, you see what they say. Some pathologists, and I guess maybe they mean people like Dr. Suster, consider this an atypical adenoma or a tumor of uncertain malignant potential, which means that Virginia Livolsi and Baloch do actually think that this is invasion of the capsule. So this is it's an issue that has not been sorted out yet. And here is a very interesting case that I have taken from an article in the Journal of, and I think it is Kakudo who's the first author in this case. And I'm asking the question, how can one be sure that all cases with incomplete invasion are truly benign? All right, so if we have this dichotomy, this is either a follicular adenoma or a minimally invasive follicular carcinoma because it's invaded its capsule. Where do you place a lesion like this, which of course would be here? If you put it would be an eye kind of lesion, because you can see that in that cartoon it's like a little mushroom into the capsule. Well, this particular case had been called benign, and this patient 14 years later developed a metastasis in the sacrum. So her tumor was not considered to have been sufficiently invasive, if I may use that term, to actually be an invasive, minimally invasive follicular carcinoma. It did not reach the level of the criteria that were required. So I just want you to understand that we are dealing with indefinite lesions over here. We do not have the criteria that can be used to always make predictions about how something is going to happen. And you will now begin to understand where this uncertain malignant potential issue of borderline or indeterminate lesions is now going to come into focus. And these tumors in the new WHO 2017 classification are called follicular tumors of uncertain malignant potential. And I think it makes sense to use this terminology because you don't want to use the term invasive, because you're not sure whether this is invasion, and you don't know whether these tumors are going to behave in a benign fashion in that they will not metastasize. So you use this uncertain malignant potential. Now, is there any way to tell the difference between a follicular adenoma and a follicular carcinoma on morphology? And the answer is no. They have the same molecular gene rearrangements or mutations. But there is something interesting that came up in gene expression profiling, which showed that you can't tell the difference between a follicular adenoma and a capsulo-invasive follicular carcinoma. But there was a gene expression profiling. This is when multiple genes were studied, that there is a difference between capsulo-invasive follicular carcinomas, minimally invasive follicular carcinomas, and those that are angio-invasive. And this is important, and therefore, I don't think wasting too much time on whether the capsule has been invaded or not is as important on really looking for angio-invasion in all encapsulated follicular lesions, because angio-invasive encapsulated follicular carcinoma may be a completely different disease. So just to recapitulate, what was the WHO criterion for minimally invasive follicular carcinoma? It was full thickness invasion of the capsule, and we've discussed how it may or may not be easy to to make this diagnosis, endothelial lined tumor within a vessel, and you had to qualify angioinvasion and capsular invasion with how much or how widely was this invasion present. I think a lot of people are familiar with this. If you have just less than 4 foci, at least according to this paper by Hossein, of angioinvasion, the 5-year survival was, recurrence-free survival was 100%, whereas if you had more than that, it fell down to near 20%. So given this, the metastatic behavior of these encapsulated follicular patterned lesions was, if you had extensive transcapsular invasion or unquestionable vascular invasion of greater than 4 foci, then these tumors had a definite risk for metastasis. Any other, and mark my words, any other encapsulated follicular tumor is unlikely to metastasize and probably does not merit aggressive therapy. And what is this aggressive therapy? Total thyroidectomy and radioiodine ablation. So, given all of this, as far as these follicular lesions are concerned, follicular adenoma versus minimally invasive follicular carcinoma, we have seen a revision of the WHO 2004, which talks about minimally invasive. Of course, there was always widely invasive follicular carcinoma. It went through a revision not in the WHO, but in the AFIP classification, in which the same minimally invasive tumors were subdivided into those with only capsular invasion, those with limited vascular invasion, less than 4 vessels, and greater than 4 or extensive vascular invasion. The most recent WHO classification is minimally invasive, encapsulated, angioinvasive, and widely invasive. So minimally invasive is the same as those minimally invasive tumors with only capsular invasion. There is the ones with vascular invasion are called encapsulated angioinvasive. The term minimally invasive is not used for an angioinvasive tumor which has a capsule. And then, of course, you have the widely invasive tumor. Now we come really to the most contentious issue of all, which was contentious. Now there is less contention about this, and this is the encapsulated follicular variant of papillary thyroid carcinoma. Just to remind you very quickly that any tumor in the WHO 2004 classification that had the nucleus of a papillary thyroid carcinoma, whether it was entirely follicular or not, was called follicular variant of papillary thyroid carcinoma. If it was encapsulated, it was called encapsulated follicular variant of papillary thyroid carcinoma. And this is one such tumor which was responsible for much of the thyrophobia that has gone on in the past few years. And what was the anxiety that pathologists had with this encapsulated FVPTC? It was easy to diagnose when the nuclear features were diffuse and obvious, but it was not very easy when these features were focal or equivocal. But more than that, the majority had an excellent prognosis. And those cases with multifocal NFPTC or equivocal features that were reported to have late systemic metastasis, those patients, when you reviewed them, always had angioinvasion. So it was the angioinvasion that gave a bad prognosis to these lesions, rather than the fact that they were actually thyroid carcinomas. And the problem was, many surgeons would perform a total thyroidectomy for this lesion because of the word carcinoma. Can you hear me? Have you lost
Yes,
me?
ma'am.
can hear you.
Me?
Yes, ma'am. We can hear you.
All right.
Yes.
Okay. Because there was some disturbance, I wondered. All right. And the other thing was, and which is true, I tell you, it's true in thyroid disease even today, that you send it to an expert and you may get an opinion that is at variance. And my rule of thumb was in those days, if you wanted to get another opinion, then I would send it to somebody whom I knew would agree with me, because this was a contentious issue, and to a large extent, that contention, or this, the whole problem with EFEPTC has been resolved. And I'll tell you how it got resolved. Now, before that, let's come to this: circumscribed follicular lesions with equivocal features. What should we call them? This was a big problem once upon a time. And should you call them, okay, even if it has a few of these features, should we call them encapsulated FEPTC? Should we call them follicular adenomas with some nuclear features of papillary thyroid carcinoma? Or say, confess your ignorance and say, maybe I don't know whether it's a follicular adenoma, because remember, these are not invasive. There is no invasion. Or follicular variant of papillary thyroid carcinoma, or maybe you can invent a name. And some people did invent a name. And once again, you see Rosai over here, yes, and you see Virginia Livolsi, and you see John Casey Chan, and you see Edie Williams. They were part of this group that studied the papillary carcinomas that occurred after the Chernobyl disaster, and they found they had exactly the same problem. If you had an encapsulated follicular pattern lesion with nuclear features of papillary thyroid carcinoma, when they were obvious, well, they call them papillary thyroid carcinoma, because that in the year 2000, of course, that's what those tumors were being called. But if they were equivocal and there was capsular vascular invasion, then they used the term well-differentiated carcinoma, not otherwise specified, because they didn't know whether they should call them well-differentiated follicular or well-differentiated papillary carcinomas, because the nuclear features were equivocal. But if there was no questionable, or there was questionable capsular or vascular invasion, and you had equivocal features, they invented this term, which has now been adopted in the new WHO classification as well. They call them well-differentiated tumor, because they didn't know whether they should call it follicular or papillary, or uncertain malignant potential. So it is WDT UMP. Right. Now, you would think that if everything was so easy, that experts would agree. And it became very obvious that when experts were asked to look at or examine cases and categorize them, and this was one paper where you had 10 experts, all these reviewers were experts, and they were given 87 tumors and asked to classify them either into follicular variant papillary thyroid carcinoma, follicular adenoma, or follicular carcinoma. And I just want you to see, this is the percentage of cases that people agreed on. Now you will find that 5, 6, 7, and 8 all, and the 6 in particular, called everything follicular variant of papillary thyroid carcinoma. There were others who didn't agree. There were others who called things follicular adenomas, and these were all the same cases. So there was obviously something that was going on. So what was the solution that people talked about? They said you have to use strict criteria. The problem is that people are not using strict criteria. And the strict criteria already existed. They were laid down by John Casey Chan, and you can look them up in the American Journal of Clinical Pathology. What he said was that you cannot make exceptions. That means everything that you expect to see in papillary thyroid carcinoma in the nuclei should be present. Okay, so he had primary criteria and he had secondary criteria, and you can read them over here. The usual crowding of the nuclei and clear or pale nuclei to the entire lesion, prominent nuclear groups, Samoma bodies. If you had one, if one was missing, then you had to have some 4 of the following had to be there. So use strict criteria. Okay, so strict criteria were used, and once again you didn't have any agreement upon with experts. Okay, there was expert number 5, as you will see, called everything follicular variant of papillary thyroid carcinoma except for one case which everybody called benign. Similarly, expert 3 called most cases follicular variant of papillary thyroid carcinoma. Remember that they are all looking at the same cases, 15 of them. And on the other hand, you had expert number 6 who called very few things papillary thyroid, follicular variant of papillary thyroid carcinoma. For him, most of these lesions were benign. Now, it became even more interesting because except for one expert, and that was expert number 5, who called everything follicular variant of papillary thyroid carcinoma, when they shuffled the cases around and gave it to the experts to look at again, it showed very clearly that if they got out on one side of the bed in the morning, they would call it one thing, and if they got out the other side of the bed in the morning, they would call it the other thing. So there was absolutely no way in which they agreed. Okay, so there was no consensus. Then somebody did a very brave thing and went back and looked at what would be the impact of changing the criteria and making a follicular adenoma, which had been described a long time ago, into the follicular variant of papillary thyroid carcinoma. And what did they find? That they made benign lesions into malignant in 12% of the cases, but they had no clinical ramifications in the patients with a changed diagnosis. So whether you call something a follicular adenoma or you called it an encapsulated variant of papillary thyroid carcinoma, it didn't make any difference. And sooner or later came another paper that said that there are 2 kinds of follicular variant of papillary thyroid carcinoma. One is infiltrative and diffuse, and that behaves like a true papillary thyroid carcinoma. And the other one is encapsulated, and that is an entity that is close to the follicular thyroid adenoma and the follicular thyroid carcinoma. In other words, these tumors did not behave like papillary thyroid carcinomas, although they had the nuclear features of papillary thyroid carcinomas. If they were encapsulated, they behaved like follicular thyroid tumors, the ones that were not papillary. So when all of this came through, the question was, is this follicular variant of papillary thyroid carcinoma truly a papillary carcinoma? We've just seen it does not behave like a papillary thyroid carcinoma. Its molecular profile, moreover, was closer to follicular neoplasms than classic papillary thyroid carcinomas. You know that papillary thyroid carcinomas have BRAF mutations and RET PTC translocations. These were never found in this encapsulated variant, which people were calling EFVPTC. RAS mutations, on the other hand, which are seen in follicular lesions, were exclusively seen in this EFVPTC and not in the diffuse variants of papillary thyroid carcinoma. And also the PAX8 PPR gamma rearrangements were seen in some of these EFPTCs, but were not seen in papillary thyroid carcinoma. So it is becoming evident that this term that papillary thyroid carcinoma being given to the encapsulated variant, which was follicular, was not going to be tenable for long. So this is just a little cartoon that I have, constructed. You have a classical papillary thyroid carcinoma, which is papillary, but maybe show some follicular areas. On the other hand, you have our follicular adenoma and minimally invasive or minimally invasive follicular carcinoma, which has a capsule. And in between, you have these follicular patterned lesions with papillary thyroid carcinoma nuclei. And it was becoming evident that if these were non-encapsulated, invasive and diffuse, they behaved like papillary thyroid, papillary thyroid carcinomas. If they were encapsulated, they behaved like follicular lesions. They did not behave like papillary thyroid carcinomas. So then I had some questions, and my questions were simply this. If EFVPTC, as we were calling them then, is more closely related to follicular neoplasms, shouldn't the criteria for defining benign versus malignant be those used for follicular neoplasms? Maybe if we should call them benign or call these things adenomas if they are not invasive. And if they are invasive, then invasive with angio-invasive invasion or invasive without angio-invasion. Then the other question that follows naturally from this is, if this is the case and you can get lesions with papillary thyroid carcinoma that are entirely follicular and are related to those that are encapsulated, are related to follicular neoplasms, then should we retain this definition of follicular neoplasm by exclusion? Because as I said, we had defined all follicular neoplasms as those that are follicular but do not have the nuclear features of a papillary thyroid carcinoma. Or should we now start doing molecular profiling on all of these cases? Well, these were questions, and the question then that came to me was, does it matter? And if so, when does it matter? And I think that we should listen to what Julian Huxley had to say in a lecture at Memorial. What did he say? That cancer must be defined in terms of what the tumors do, not what they look like. Otherwise, the term ceases to have biological meaning. And remember, we only called these tumors that had a capsule. They were not invasive at all. We called them papillary thyroid carcinoma with a C, because their nuclear features look like those of standard papillary thyroid carcinoma. And these tumors did not behave in the fashion that you expected carcinomas to behave. They did not metastasize, and as far as we could tell, the only ones that did were those that showed angio-invasion. So if you had a non-invasive encapsulated tumor, then did we have the right, just because they had papillary thyroid carcinoma nuclei, to call them papillary thyroid carcinoma? So these were the questions that came to my mind. And I drew this little cartoon to tell you what the problems were. These were, not the problems, but how we understood encapsulated follicular pattern lesions. All right? If you had a follicular pattern lesion in which the nuclear features of papillary carcinoma were absent, we just looked to see whether there was invasion of the capsule or no invasion of the capsule and no angio-invasion. And if it was non-invasive, we called it a follicular adenoma. If it was invasive, we said with angio-invasion, then it became a follicular carcinoma. Without angio-invasion, we called it minimally invasive follicular carcinoma. If the nuclear features of papillary carcinoma were present, we were calling all these tumors, despite the fact that there was no invasion, encapsulated follicular variant of papillary thyroid carcinoma. And then, of course, we had those where the nuclear features were equivocal or uncertain or focal, and then these were being called follicular neoplasm of uncertain malignant potential. And if you draw, a line that encompasses, or a border that encompasses these lesions, leaving out the frank follicular adenoma and the frank follicular carcinoma, which is the angioinvasive encapsulated variants, all of these, if you look at them carefully, they really could be encapsulated in one group. And what was that? Encapsulated follicular patterned neoplasms of low clinical risk. All of these had no great potential for metastasis. Now that was, that was what I used to, sort of have a great deal of angst about. I honestly felt that we were over-treating many of these patients because we call them papillary thyroid carcinoma, or we call them minimally invasive follicular carcinoma. The surgeons would use that word carcinoma and possibly, do surgeries or treat patients in a more radical way than they needed to be. And my prayers were answered because all of you are now aware of this paper that came like a bombshell published in JAMA Oncology on April 14th, 2016. I cannot forget that date because it said nomenclature revision for encapsulated follicular variant of papillary thyroid carcinoma. And it says over here, a paradigm shift to reduce overtreatment of indolent tumors. And what did they recommend? That these tumors should be now or henceforth called non-invasive, because they were non-invasive, follicular thyroid neoplasm, okay, because it comes from, follicular, they look follicular, but they have papillary-like nuclear features. And so NIFTP has now become a very important entity, which I think has taken away the onus on pathologists to be, to call these things papillary thyroid carcinoma, and therefore these patients are not being over-treated. So how will you define them? Well, first of all, there should be encapsulation or clear demarcation. And this means that perhaps you don't need to see a real capsule. A follicular growth pattern with less, in the beginning they said less than 1% papillae, no Samoma bodies, and no more than 30% of solid or insular growth, and nuclear score 2 or 3. In other words, their nuclei should be like what papillary thyroid nuclei look like, except nuclear score 3 was one where you had large numbers of these vacant looking nuclei. If you had a pseudo inclusion here or there and you just had grooves, then that was nuclear score 2. There should be no vascular or capsular invasion, no tumor necrosis, and mitotic activity should be less than 3 mitoses per hyperphi. Now these criteria have been revised since then, and there should be complete absence of papillae, and nuclear score 3, they feel should be more towards 2 than 3. So they've put it as stroke 2, stroke 3. So now that we know that this is not a papillary thyroid carcinoma, or at least we should not be calling it papillary thyroid carcinoma, there are some questions that have been thrown up. And the first one is, can the distinction of NIFTP from, follicular variant of papillary thyroid carcinoma, which may be diffuse, can it be made on cytology? And the answer is no. So if absence of invasion is a criterion for the diagnosis of NIFTP, then why aren't we calling it a follicular adenoma with PTC-like nuclei? Well, I think it is, but obviously those who wrote the paper thought that it would be better for them to use the word tumor rather than say adenoma. And now comes this question that comes up again and again. How extensive should the foci with nuclear features of papillary thyroid carcinoma be for the diagnosis of NIFTP? And the answer is that it is not defined. Okay. So, but I look at it this way, that if NIFTP is a RAS lesion with PTC-like nuclei, I don't think it would make any difference at all. The next question is, what term should apply to NIFTP when it shows capsular or angioinvasion? It's all very well to say that NIFTP is a lesion with an intact capsule which is not invaded. So what will you call an NIFTP when it shows capsular and angioinvasion? Are you going to call it minimally invasive follicular carcinoma or angioinvasive encapsulated follicular carcinoma with PTC-like nuclei? Or are you going to call it follicular variant of papillary thyroid carcinoma because it has shown invasion? And I'm not sure what the answer to that question is. I'm just sure that of one thing, and I ask this as a question, and that is, was this term NIFTP created to soften the shock to the system? It was a big shock to the thyroid system, I can tell you, pathologist system, that would have inevitably occurred if a malignant diagnosis was changed overnight into a benign one. And I think that's the reason why we are not calling them adenomas. Okay. Now I want to show you this picture. You can see here that there's a capsule. You can see invasion of the capsule. And this is a follicular tumor which has got papillary thyroid nuclei, and it's invading the capsule. What are we going to call? And if you look here, maybe you will see some vague papillae-like structures. What are we going to call that? Are we going to call that follicular variant of papillary thyroid carcinoma? Or are we going to call, true follicular variant of papillary thyroid carcinoma because it is invasive, or the minimally invasive NIFTP, whatever that means? All right, so just to tell you that in the last few minutes, that we have been talking about the molecular pathology of all of these lesions. Okay, when we talk about papillary thyroid carcinoma, we know that a thyroid follicular cell, if it has either a BRAF mutation or a RET PTC translocation, it becomes a papillary thyroid carcinoma and behaves like one. And most of these tumors, in fact, I would say the majority of them, have conventional PTC-like nuclei. Now, when the follicular cell undergoes a RAS mutation, two things can happen. It can show the features of an NIFTP, or it may show the features of a follicular adenoma. And when this undergoes a PAX8 PPR gamma or a PAX8 PPR gamma mutation, either of them, what happens is that you get in the NIFTP, it's obviously invasive now. What are you going to call it? And people are calling it RAS-like PTC. Here we call it follicular thyroid carcinoma, minimally invasive or widely invasive, because you can get a widely invasive carcinoma with the same change. And this is my real question. Okay? And I think that we should be looking at thyroid carcinomas or thyroid tumors not as a benign versus malignant kind of continuum, right? You have benign tumor, which is a follicular adenoma, and we're talking of here follicular patterned lesions. You have borderline tumor, which is follicular tumor of uncertain malignant potential, and that's when you are unable to say whether this is it is capsular invasive or not. It is indefinite for capsular invasion. Then, of course, you have NIFTP, and you have this well-differentiated tumor of uncertain malignant potential when the features of papillary thyroid carcinoma, the nuclei, are equivocal or they are very focal. So this you would call a borderline tumor. Then we know that there is a minimally invasive follicular carcinoma, which is a carcinoma with a low risk. And then you have the moderate risk cancers, which is any angioinvasive tumor, whether it is encapsulated or widely invasive, and the widely invasive follicular carcinoma. And the very high grade risk is polydifferentiated thyroid carcinoma, which I'm not talking about today. But what happens when you have a RAS, when you have a minimally invasive tumor, which started out as an NIFTP? What is it? A RAS PTC? That means a RAS expressing a mutated papillary thyroid carcinoma? Or would you want to call it a minimally invasive NIFTP? And I don't think the answer has come. And that's exactly what I have said now. My 2015 cartoon has become a cartoon in 2020, in which what was EFVPTC is now NIFTP, when you had the nuclear features of papillary thyroid carcinoma present in an encapsulated follicular neoplasm. If there was no invasion, it is now NIFTP. With invasion, I don't know what we are going to call it or what they're going to recommend we call it. But whatever it is, apart from that, all of these tumors, now you have this follicular tumor, it's not follicular neoplasm, but follicular tumor of uncertain malignant potential, and this well-differentiated tumor of uncertain malignant potential. That's when invasion is indefinite, and here where the PTC nuclei are indefinite. All of these tumors are tumors of low clinical risk. So that brings me to just the last two things that I want to talk about. What is the meaning of low clinical risk, and how do we as pathologists, what is our role in the management of differentiated thyroid carcinoma? Now, the first thing is FNAC, and I'm not going to say anything about it because much about it, because Asavali will tell you a little bit. But I want people to understand one thing, all right? That FNAC is very sensitive and specific for papillary carcinoma. But when you do FNAC in the diagnosis of thyroid nodules, in goitrous lesions, where a variety of follicular lesions are common, that is adenomas, dysfunctional nodules, etc., then the positive predictive value of FNAC is low, because in those areas where you have a lot of papillary thyroid carcinoma, when you hit a stone in that direction, and I mean that as FNAC, you are going to pick up papillary thyroid carcinoma. So the positive predictive value will be high. But if you have a large area of a variety of different follicular patterned lesions, whether encapsulated or not, you do an FNAC and your positive predictive value is bound to be low for carcinoma. So remember this, that FNAC has to be interpreted, the value of FNAC should be interpreted not from simple things like false negative and false positive. It should be interpreted with the negative predictive value and the positive predictive value. The other thing is frozen sections. Now, what is the value of frozen section in the nodule when FNAC is ambiguous? Well, frozen section, I would say, has a very narrow edge over FNAC for papillary carcinoma and virtually none for follicular lesions. it is, I think, becoming less and less relevant in the era of risk-adapted management. I know that it is often requested, but I will stick my neck out and say that it is seldom useful, unless you're dealing with a medullary carcinoma or some other carcinoma that is very easy to identify. And finally, this issue of lobectomy versus total thyroidectomy. This was really more for clinicians, but we should know as well the significance for management of what we report. Now, I keep circling this risk adapted management is what is being used to decide whether something should be less extensive surgery versus more extensive surgery. And most of this means a lobectomy versus total thyroidectomy. But what we should understand, and I think clinicians should also understand, that carcinoma does not always mandate a total thyroidectomy. And I will show you the ATA risk for differentiated thyroid carcinoma, that is the American Thyroid Association. And just look at the bottom of this the screen. You will see over here that patients with intrathyroidal differentiated thyroid carcinomas, and that means all thyroid carcinomas, including papillary carcinomas, it doesn't include just encapsulated lesions, with no evidence of extrathyroidal extension, vascular invasion or metastasis, just look at the recurrence rates. They are extremely low. So these are very low risk tumors as opposed to the really high risk tumors where there is gross extrathyroidal extension, the tumor has not been resected, well, etc., etc. Now, on all this, some of these risk factors, including also the size of the nodule, have been taken into consideration in the AJCC staging, that's the 8th edition. And I think this is one of the few staging systems that actually divides up low risk and high risk patients based on age. And this has come from, the previous risk stratifications, which were called AMIS and AGES and so on. And here you have younger patients. Once upon a time it was 45, now it is 55. Those who are younger than 55, those who are equal to or higher than 55 years, older than 55 years of age. And you will notice that there is no stage 3 in patients who are younger than 55 years of age. So if you're less than 55 years of age, stage 1 is all patients without distant metastases, regardless of the tumor size, lymph node status, or extrathyroidal extension. If there is distant metastasis at the time that the patient is seen and the patient is less than 55, it's stage 2, because they have such excellent expected disease-free survival. And therefore, one would have to tailor the surgical intervention according to this, the stage of the disease. Now, older patients, that's where the size of the tumor comes into play. So if you have a 4 centimeter or less sized tumor and the patient is younger or equivalent to older than 55 years of age and it's confined to the thyroid, it is stage 1. All right. Stage 2 is where you have extension into the same tumor size greater than 4 centimeters, gross extrathyroidal extension into the strap muscles and lymph nodes, but only if the patient is greater than 55. Note that lymph nodes do not change the stage in a patient who's less than 55. And finally, stage 3, where all of these, but now the extrathyroidal extension is into the subcutaneous tissue or the larynx or the trachea. That means it's beyond the strap muscle. So my last slide is this, and this is the message to all pathologists. Do not obsess over capsular invasion or nuclear features of an encapsulated, entirely follicular patterned lesion. Okay, we do have an entity now called NIFTP, but even if we are not sure whether we are looking at an NIFTP And there are some nuclear features that look like papillary thyroid carcinoma. We don't know whether it's more than 50% or 10% or whatever. Please do not obsess over it, because these are all follicular neoplasms of low clinical risk. Angioinvasion is what we should be concentrating on. It is of great clinical significance whether or not the nuclear features of papillary thyroid carcinoma are present. So we should be looking for angioinvasion, right? And I think this goes without saying that we must have a rapport with clinicians, because today in the era of risk adapted therapy, clinicians need to know from us pathologists some features, particularly the size of the lesion and the presence of strap muscle invasion, but that they will be able to see grossly. We don't need to really spend too much time. We can make a diagnosis, or we can note that there is some extrathyroidal extension, but as long as it is not into the strap muscles, that microscopic extra thyroidal extension does not really make a difference. So with that, I thank all of you, and I hope you enjoyed this as much as I did. Thank you very much.
Thank you, ma'am, for that wonderful talk. Now I invite Dr. Asavari Patil to give some comments.
Yes, Asavari,
Okay.
please.
Well, actually, there I think people are able
Close
to.
screen share.
Now tell them something about grossing. How to gross an encapsulated
Yeah,
lesion.
Screen share.
I just want to show that if I want to share my screen, but before that, I must thank you, madam, because this is a topic which is very easy to understand when I read the textbook. But when we are practicing, it is something like every other week we are exchanging slides. Okay, what do you think? Is it capsular invasion or vascular invasion there or not? So you have really made this topic very simplified and where to concentrate. So let me share my screen. And something I want to say that first is about FNSC part, which we know that this is the Bethesda system that we talk about for reporting cytopathology. And that is one of the most important modality for assessing any thyroid nodule along with ultrasound. I just want to know, am I audible clearly?
Yes, you are, but maybe you can
Yes, ma'am.
make it a full screen.
Yeah, sure. Yeah. So with the along with ultrasound, FNSC is indicated in certain conditions when the size of nodule and ultrasound interpretation is taken into consideration. And this is a good flow chart showing it is from ATA guidelines. But Bethesda system that we are using for reporting thyroid cytopathology, we know that there are 6 categories ranging from non-diagnostic to malignant, and all of them are important because they carry these clinicians act on our the category that we are going to put under a particular lesion, especially benign, that will not need any further immediate intervention, surgical intervention, but other categories like category 4, 5, or 6, they will require surgical intervention. So just to look at this category 1, 2, 4, and 6, the problem is when we get this category 4, where we are not sure whether we are looking at really a follicular neoplasm or suspicious for follicular neoplasm, or could there be any follicular variant of papillary thyroid carcinoma or NIFT-P or NIFT-P. So what do we do now? So as per revised guidelines, we always put this note, we should put this note that although architectural features suggest a follicular neoplasm, some nuclear features raise possibility of invasive follicular variant of papillary thyroid carcinoma or the indolent counterpart. So that would be the best option, because we really cannot differentiate NIFTP or follicular variant of papillary carcinoma many times from follicular neoplasms, and we lump all of them in category 4. Now, second thing is grossing, but before that grossing, why it is important to know how should we gross any thyroid nodule, because I think we have already understood this this chart, where what we have to look for in any encapsulated follicular pattern thyroid tumor is capsular or vascular invasion, which is a vascular invasion again in the capsule or nearby, and nuclear features of papillary thyroid carcinoma. And the way to approach that is whether you look for invasion and whether there are any PTC like nuclear features. So for crossing, what we need to do is braidlock the thyroid lobe, or we can slice it or bisect it parallel to the long axis of lobe. And here I want to focus on, because if this is a nodule that we are looking in the thyroid with the unremarkable thyroid adjacent to it, our section should include the nodule plus the capsule and the adjacent thyroid, because this is the area where we are going to look for real capsular invasion or vascular invasion. And same is true for the thyroid nodule along with the adjacent tissue, because if at all it turns out to be cancer, we need to look for extrathyroidal extension. And this is how we submit all these sections. So with this, again, I transfer this to Madam.
Sure. If there are any questions, I'd be very happy to answer them.
Yes, ma'am, there are questions, and now we'll go to the question and answer session. And the first question is, if we have to determine number of foci of invasion, what is the minimum sections of capsule we need to take in grossing?
Well, I think you should try to get as much of the capsule as present. The rule of thumb is that if you have a lesion that is 5 centimeters or less, 4 centimeters, I guess, is also good. Then you should try and include the entire capsule, and it should be in 8 or 10 sections. If it's a large nodule, then any 1 centimeter above 4 or 5 centimeters, whatever is your rule of thumb, then submit 1 additional section. I would also ask Asavari if that is the rule of thumb that you are using at Tata Hospital.
Yes, that's what we are doing. We try to first is cross examination to find out obvious any capsular invasion focus. If you can find out, if we don't find out, submit extensively. But many times we have to go back if we don't find any capsular invasion. So whenever possible, we try to submit entire capsule along with adjacent thyroid if we want to rule out cancer.
Okay. Yes. Okay. So we'll go to the next question. What are the criteria for extrathyroid extension? How do we give pathological staging if specimen does not consist strap muscles?
Well, as I said, extrathyroidal extension is something that the clinicians should be looking for, because it's gross extrathyroidal extension. We can only look for microscopic thyroidal extension, and we can only say so far and not further, and that's what we have to understand as far as pathological staging is concerned. And normally, if it is involving the strap muscles, they will remove the strap muscles with it. They don't leave the strap muscles behind. So you will also have an opportunity to examine the strap muscles, and you will also see that there is gross extrathyroidal extension. So I don't think that is a very difficult issue. Anything to add to that, Asavari?
As you said, madam, it is extrathyroidal extension. We always say that it is microscopic, and it matters to the surgeon when it is gross, when they are removing the thyroid. So usually the surgeon knows when he removes the thyroid. And whatever we are commenting, we do comment that extrathyroidal extension present, but we know that this is just a microscopic and which may not add to any, it's may not be decision making for treatment purpose.
Right. Okay. So going to the next question, is there any importance of number of foci of capsular invasion in prognosis of follicular thyroid carcinoma?
Yes, I think there is, because if you have a number, and I don't think that there is a number, but if you see that the capsule is got multiple invasive areas, then that I think would be a widely invasive follicular carcinoma, although widely invasive follicular carcinomas don't actually have to have a capsule. So you can get just wisps of capsule or no capsule, and you can get a very frank invasive follicular widely invasive follicular carcinoma. But I think that it's a good idea to not just say that this is a minimally invasive follicular carcinoma or it is an invasive follicular carcinoma, without saying how many areas of invasion there are. And if there's more than, at one time I think they said if there was more than 4 areas of invasion, I forget exactly the AFIP classification, but you will know when this tumor is, all over the place. And I think that's what a widely invasive follicular carcinoma. Is there anything that you would like to add, Asamri?
I don't think so, madam, because as we either get a carcinoma with 2, 3 foci or maybe single focus of invasion. Otherwise, it's always like almost widely invasive with, as you said.
Exactly. So I don't think we sit to count them. It's very obvious when you have a widely invasive carcinoma. There's one question I think maybe I would like to ask Asavari. There are a lot of pathologists who believe that all follicular carcinomas actually arise in encapsulated nodules. That they all begin life as encapsulated follicular neoplasms. And I'm not very sure about that. I think that you can get follicular carcinomas that are widely invasive from day one. And therefore, I feel this obsession with looking for a capsule to make a diagnosis of an invasive follicular carcinoma sometimes makes people or they don't recognize an invasive follicular carcinoma because it is so widespread. And this, I feel, is something that we should try to, or I would like to dispel the notion that you always get a capsule in a follicular carcinoma, and that widely invasive carcinomas arise in encapsulated lesions. I don't think they necessarily do.
So I agree with you, madam, because as I was listening to your lecture, you put all those categories like encapsulated follicular pattern tumors of low clinical risk, and these are, I think, totally separate category. And those widely invasive tumor, they are totally different kind of tumor, although they share the nuclear features maybe. But it could be like de novo widely invasive without any capsule. But I have not come across any small follicular carcinoma without any capsule. I'm not doing that.
No, small ones. I'm talking about, large ones, and sometimes they occupy follicular lesion. Follicular carcinomas occupy the entire lobe of the thyroid, and there is no capsule to be seen. But they look so differentiated that people may miss the fact that they are follicular carcinomas. And I have seen that happen, and I think we should be aware of the fact that when you do a gross examination, if this is really nothing but a hyperplasia or some other kind of benign disease in one lobe, where one lobe is sort of hugely enlarged and the other part of the thyroid is not enlarged, then you must go through your mind that this, and you look at the gross, and that gross has got that whitish kind of appearance, that this is a neoplasm. This is not just, multinodular hyperplasia or some other disease. And I know that pathologists are reluctant to make this diagnosis because they're not seeing any capsule, and looks like a diffuse, sort of sometimes nodular and sometimes diffuse disease in one lobe of the thyroid. But it's very unusual to get a single lobe that is enlarged in a benign non-neoplastic disease, as well as the appearance when you have no colloid in that tumor. You don't get that brownish appearance of the neoplastic gland.
Yes. Okay, we'll go to the next question. If benign-looking thyroid follicles are seen in the neck dissection done for suspected PTC, how to approach such a lesion? The thyroid on extensive sampling showed features of Hashimoto's thyroiditis, though. Does IHC have any role to play?
Well, the answer to that last, does IHC have any role to play, is no. All those galectin 3 and God knows all the various things, and CD10 and lots of other things that we used to do, I don't think helps you at all. I think what the question is about is lateral aberrant thyroid, and does lateral aberrant thyroid actually exist? Now, I think that we can only say that lateral aberrant thyroid exists if the thyroid hasn't been examined. So I think it would be a little, what would I say, premature to make this diagnosis when you just have the lymph node and you have thyroid tissue in the lymph node. You are, I think, duty bound to expect that the thyroid should be examined, particularly if this is a young person and the thyroid otherwise appears to be normal. I think at least a lobectomy on that side would have to be done, because there are microcarcinomas that are present in the thyroid, which have been found in the majority of cases where you have thyroid tissue within the lymph node, albeit that you may not see the thyroid, the classical features of papillary thyroid carcinoma in those nuclei. In a case where there is diffuse involvement of the thyroid by Hashimoto's disease, sometimes you get nodules outside of the thyroid. This happens with Hashimoto's disease, and it happens with hyperplasia of the thyroid gland. When you have maybe strong TSH stimulation or some other reason to have a hyperplasia of the follicles, yes, you can get not one, but sometimes more than one nodule outside the thyroid gland. And in Hashimoto's disease in particular, you might have a rim of lymphoid tissue around the periphery in thyroiditis, and you may mistake that for a lymph node. So sometimes this is the real issue, and not disease in the lymph node. That means not disease, but finding thyroid tissue in a lymph node and then finding Hashimoto's thyroiditis in the thyroid gland. So I think it's difficult. I think it's a difficult issue, but I don't think you should castigate yourself too much, because if there is genuine thyroid tissue in a lymph node, you cannot say that it is a lateral aberrant thyroid or something like developmental if you have not examined at least the lobectomy on the ipsilateral side.
Okay. The next question, if we have multinodular goiter and only a tiny focus shows papillary features, what should we call it?
I'm not quite sure what you mean by papillary features. Are you saying a multinodular goiter in which some of the nodules have some nuclear features of papillary thyroid carcinoma? If that is the case, as I told you, these nuclear features of papillary thyroid carcinoma, by the way, are not only seen in papillary thyroid carcinomas. Hashimoto's thyroiditis regularly shows nuclear features of papillary thyroid carcinoma, And I know that I have fallen into this trap on one occasion when I overcalled Hashimoto's thyroiditis on FNAC as papillary thyroid carcinoma, because we did see the nuclear features that were very prominent in that particular case. So I think that even in multinodular goiters, there is no reason why you may not see some foci which show you, nuclear clearing, etc. But if the real orphan Annie nuclei and the very clear nuclear pseudo inclusions and chewing gum colloid or whatever is hardly ever seen in a multinodular goiter. So I think we shouldn't overcall those cases. In any case, we shouldn't be overcalling in these cases papillary thyroid carcinoma at all. Just don't obsess about it, because you are not going to be missing out on a significant disease that is going to have cause problems to the patient.
Right. Agree, ma'am. With the last question, if you have a sub-centimetric incidental NIFP with widespread nuclear pseudo-inclusions, do you think second generation IHC with BRAF V600E and or P27 has any role?
Well, yes, there is always a role for sort of molecular pathology, but it has to be in a context. If you've got a nodule and your protocol says that when you reach this the indeterminate sort of category in the Bethesda classification, there is a recommendation that you would use molecular studies. Okay, but you know what they cost? They cost the earth. Okay, now you've got a sub-centimeter nodule and you want to use BRAF, and I didn't understand, was there this patient obviously hasn't got any metastasis, isn't that right? I think that was part of the question, or I can't remember.
Yes, it is. There is a sub-centimetric incidental NIFP.
Yeah, okay. So you only know that it is an incidental NIFP when you have taken it out, right? Yes. And it's there. Okay. So you know that NIFP is not a great, is something that doesn't require anything further to be done. So why would you, go for doing any of these molecular tests? I don't think it is really important. I think, molecular tests are very important in a country like the United States, where nobody wants to have an operation. Having an operation can cost the earth. And, you have surgeons are sued for voice quality change and all kinds of such things. I feel there you would want to avoid doing surgery. And I think that in those sort of situations, yes, it's worth doing some molecular tests. Those that have, a high negative predictive value, which tells you that this nodule is very unlikely to be a tumor, and therefore you can watch and wait. You can watch this patient and see how this patient behaves. However, if you have put a needle into this thyroid and you have an indeterminate follicular lesion, okay, or you don't know whether this lesion is likely to turn out into a papillary thyroid carcinoma, then yes, maybe you will want to do a molecular test which has a high positive predictive value, so that you will then know for certain whether this is a tumor and what you should go ahead and do about it. So once again, when you've already removed the thyroid and then you want to find out whether there is a BRAF mutation or something, I don't think really makes much sense.
All right, ma'am. There's one last question. How useful is IHC CK19 in follicular variant of papillary thyroid carcinoma?
As I said, it's not useful. Okay, I think most of these things at one time came about with great promise, and people used it. I think a lot of these now, at least in this country, and I have seen posters being presented at our meetings or sometimes at regional meetings. It's to give some kind of thesis work to students in training. That means postgraduate students, and they do one or the other of these markers, and usually come to the conclusion that more studies need to be done to prove the point. I think that enough studies have been done to show that none of these immunohistochemistry markers, whatever you say, is really going to be of much clinical use in a particular case. So you study 50 cases, you will show that some 30 cases showed you some positivity and they turned out to be X, and some. But when you have one case that you have to make a decision on whether this patient has or does not have a papillary thyroid carcinoma, I don't think immunohistochemistry helps. And I honestly think that if one sort of has a practical way of looking at thyroid disease, many of these problems that we imagine are there will disappear. Okay?
Yes. Thank you so much, ma'am. I'll hand over to Priya.
Thank you so much.
Thank you, ma'am. Thank you.
Thank you, Asawari.
Anita, there is
Thank you so much.
Anita, there's a
Yes.
question. I think
It was
either you
it was
or Asawari can answer.
Okay.
Yeah.
Question, sir.
There's one more question I thought is an
Yes.
important question. I think young pathologist wants to know what's criteria to call a margin positive, and do this have a prognostic or a clinical
I didn't
significance?
hear the question completely. Sorry.
When I didn't get
What is the criteria to call a margin
A
positive?
margin positive.
Do this have a prognostic and clinical significance?
Well, I think that margins being positive in thyroid cancer are very, very infrequent unless the surgeon knows that he's got extrathyroidal disease and he's trying to do an R0 resection, in which case, yes, we must look at margins. And I think the margin, just like in breast today, is ink on the margin. So if you have inked the margin and the tumor is where the ink is, then that is a margin positive. Okay, we ink everything because that's the protocol that one has to follow. But I don't think that too many of our margins come positive in the thyroid. Okay, unless there is gross extrathyroidal extension, whether into the strap muscles or into the posteriorly or into the subcutaneous tissue, in which case the surgeon knows that he may be leaving tumor behind.
Thank you.
Thank you, ma'am. Thank you, ma'am. It was indeed a great lecture. And I would like to say here that you are one of the greatest inspiration for many budding pathologists like me.
True.
And thank you so much for all your
I didn't hear it, and I'm glad I didn't hear it.
presence.
Thank you. I think that was Priya, but Priya, your voice
Thank you
cracked
so
and I
much,
didn't
ma'am.
hear it. But I don't want my head to swell, so thank you very much for that, which I think was a compliment that you were trying to pay me.
Thank you,
Thank
Asawari
you.
ma'am, for sharing your experience with us. And thank you, Sumit sir, for giving me this opportunity. And thanks, Tanvi and Shweta.
Thank you, all of you. Yes.
Thank you.
Thanks, attendees, for attending our webinar. We hope you enjoyed it. And the next talk is coming Tuesday on 20th July. IHC Principles and Applications by Dr. Neha Mittal ma'am, Assistant Professor, PMC Mumbai. Stay tuned with us.
Thank you.
See you on next Tuesday. Until then, bye-bye. Thank you.
Bye.
Excellent.
Bye.
Very good. Thank you.
Thank you.
Thank you, ma'am.
Thank you, Asawari. That was very nice. Thank you.
Thank you so much.
Bye, Tanvi. Bye, Shweta.
Bye.
Bye-bye. Bye.